You can have acne, striae. This is usually produced by doctors only. This is produced by us. But what I want to tell you is this. You don't produce this. This is supposed to be produced by specialists, not by you. You don't touch this drug in the dose which I am going to tell you. But if you want to have this Cushing syndrome, such surrounding, the dose of steroid is what we give in diseases like, for example, interstitial lung disease. Interstitial lung disease of lungs, people used to die in 1 year or 2 years. They used to die. Today they are alive after 10 years because of steroids. But steroids in what dose? 1 milligram to 2 milligram per kilogram. That means on an average 60 milligram. 60 milligram per day for 1 to 2 months. 1 to 2 months, and then maintenance dose always around 10 milligram. When you GPs give a maintenance dose of steroid, by chance, supposing some illness, never give more than 5 milligram. Never. Because with 5 milligram, all this won't take place. So diseases like, for example, vasculitis. In the lung, we get Wegener's syndrome. These patients, so often they used to die. There was no treatment. Because of this large dose of steroids, we've been able to say the lupus patient, autoimmune diseases. There are many other indications, lymphomas and all. But the dose there they give is so high that the patient will develop Cushing syndrome. And you have to explain to the patient, nothing wrong. This is the price you're paying to live. Otherwise you would have died. And to give you confidence as a GP, let me tell you, I want to give you confidence that you will not produce this. Prednisolone, if you give in a dose of up to 100 milligram for 3 weeks, till that time all this does not take place. Side effects don't take place. The side effects take place when you give longer than 3 weeks. 100 milligram. Now, as a GP, you are not supposed to give this at any which condition you are going to give this. All these asthma patients, you give 40 to 60 milligram for 5 days, 7 days, 10 days, or at 2 weeks you can give. You can give for 3-4 weeks COPD, 40 milligram for 3-4. But 40 milligram, 3-4 weeks, you can't compare with that dose which I am telling you, which will produce side effects. So don't be afraid of using that dose in those illnesses. You will not produce Cushing syndrome. This syndrome due to adrenal tumors, very rare, you will not see in lifetime. But every day you are going to see it because patients are taking steroids, and those who are taking more steroids, they will be having this all the time. So this is as far as the more adrenal, more cortisone. Now, there is one disease now I will tell you where a GP can diagnose better than a specialist. You should be proud of this. That if you can pick up a patient which the specialists have missed, oh, you feel great. You feel great. Yes, it's not common. It's not common. It is maybe once or twice a year you might see such a patient. But it is very easy to diagnose. Very easy to diagnose. Where there is a hypoadrenal, less adrenal. That means if you see the cortisone level in the blood, it is low. This is the type of disease. And what are the symptoms? Vomiting, but with loss of weight. Vomiting and loss of weight. Vomiting, if you go on continuously, naturally you are not eating much, but still you will not lose so much weight. You are taking, in between, you go on eating something. In this disease, for example, patient says for 3 weeks he has been vomiting and he has lost 4 kilo weight. Once you hear this, and then when you hear from the patient, that he went to a doctor, he did endoscopy, it was normal. After 10 days, he got fed up, he went to another doctor, again he did endoscopy, it was normal. That is this disease. In olden days, we used to teach as Addison's disease. No, they're gone. Those days are gone. We don't see Addison's disease anymore. In private practice, you are going to see this. A patient has got less adrenal in the body, and you can pick up such a patient, you are lucky. You will make such a big name. And the beauty is what? You give this patient, your cortisol levels are low, you have confirmed. You give prednisolone 5 milligram or 7.5 milligram. You will not believe that this patient was getting 10 drugs, domperidone, PPI, proton pump inhibitors, and gastroenterologist is going giving mucin gel, this, that. You stop everything. You only give one tablet of prednisolone, 5 or 7.5 milligram. You will find within 3-4 days he puts on 1 kilo weight, no more vomiting. So such illnesses, as a GP, you should remember. Why? Because if you really can pick up, you make a big name. Make a big name. Then we come to another hormone called as PTH, parathyroid hormone. Really speaking, we have been teaching for years together that if patient has got recurrent kidney stones, get this done, because if there is a parathyroid tumor of these glands here in the neck, you have to remove it by operation, and the stones will not be formed. But in my experience, I am telling you, recurrent kidney stones are very common in normal population. If some patient comes for kidney stone, pain, this, that, then you relieve it. 40% chances he will come back again after a few years for a kidney stone. So there the PTH has no role, but if at all your PTH has got some role for GP, it is this. Whenever there is a low vitamin D3, if PTH is high, that vitamin D3 is causing mischief. That is the cause of weakness, pains in the body, osteomalacia, what you call. Only vitamin D, low vitamin D is nonsense. It has no meaning at all. At the moment, your whole population has got low vitamin D3. You do it and see in the next few levels of vitamin D3 in your patient. Nobody has got more than 10, 12, 15, 20. That's all. Normally it should be 40, 50, 60. Why it is like that, we don't know. But let's not discuss it. But what I am saying is, in this patient, the PTH will be normal. So ideally speaking, vitamin D3 levels should not be done. It should be stopped. Because you are wasting the patient money, 500 rupees. But if you want to do vitamin D3, also ask for vitamin, the PTH, parathyroid hormone, which is another 500 rupees. You are already spend 1,000. There are some laboratories now who have we have advised them to combine the two and charge less. So what they are doing is vitamin D3 and PTH, vitamin D3 and PTH, and some 600-700 rupees. So PTH is very useful to diagnose the value of low vitamin D3. Because patients are neurotic, they will make you mad. Doctor, I've got this, and my vitamin D3 is low. Because of that, I get cramps, I get this, I can't sleep. They'll make you tell them it's normal. Why? Because you get the PTH then. If PTH is normal, yes, you can give them vitamin D by mouth. The whole population can be given vitamin D by mouth. There is nothing wrong in that, because nobody goes in the sun. Then we come to the commonest endocrine, that is thyroid. Thyroid is the commonest. And there are patients who talk like that, doctor, have I got thyroid? Have I got thyroid? This is the language the patients are losing, which has no meaning. Have you got thyroid? What do you mean? This patient has got a swollen thyroid. big here, such a big. We call it goiter. This is thyroid. But the blood test will be normal. T3, T4, PTH, all the TSH, everything will be normal. So this is a normal gland, normal secreting gland, but enlarged because of less iodine in the country, like Nepal, for example. In India we don't see much of these goiters, and they remain big, swollen. If they think cosmetically, they can remove it. If not, then leave them. They will not cause any trouble. So thyroid can be a goiter which has got nothing to do with the whole body. See, there can be cancer, for example. Suppose this patient has got a cancer here, cancer nodule. Blood test will be normal, T3, T4, TSH. That is also thyroid disease. So just to say thyroid has no meaning at all. Is it a thyroid swelling? Is it a nodule in the thyroid? And then, of course, is the thyroid more? Is the thyroid less? These are the diseases of the thyroid gland. So, when you want to examine thyroid, always stretch the neck. Stretch the neck, otherwise you can't see thyroid. Once you stretch the neck, then you can see that this is the area of the thyroid. Any swelling will be seen beautifully. Now here is a lady who came for something else, some other complaint, I forget. But a general examination, I have to do everything. I have to see the whole body. So when I did that like this, I found this nodule here. Now when you see a nodule in thyroid, it is a little upsetting. Why? How do you know it is not cancer? How do you know it's not? Cancer of the thyroid is very rare, it's not common. But nowadays you can treat it even without operation, with radioactive iodine. That's not the point. The point is, if you don't stretch the neck, you will lose this sign. And once you have seen it, you have to go for sonography. But suppose there is water in it, cyst. So cyst, forget it. But suppose there is no cyst, it's solid. Then you have to tell the sonographer to do ultrasonographic biopsy to exclude cancer. Anyhow, this is about the thyroid. But the most important, then we come to the common conditions, that hyperthyroid and hypothyroid. More thyroid, less thyroid. More thyroid, called as hyperthyroidism. The also medical word is used as thyrotoxicosis. The easiest disease to diagnose in medicine is thyrotoxicosis, hyperthyroid. Easiest. 1 second diagnosis. 1 second. Without any test, without any imaging. If a patient tells you that he has rapidly lost weight, that means within 2 months he has lost 6, 7, 8 kilo. Very fast. And he has been eating food. He says, I am eating the same food. I have good appetite, I have been eating everything, and I have no other complaints, no urine complaint, he is not passing more urine like diabetic patient. He has no other complaint. Except he says, with the same diet which I was eating, the same life I was leading, he's lost weight. Not important thing is not lost the weight and all. Important thing is rapid. This English word rapid is a beautiful word. He has rapidly lost weight. Even cancers don't lose weight so fast. And if you hear this complaint from your patient, please only feel the pulse, that's all. Nothing else. This patient who was waiting in the waiting room for half an hour before you called him inside. You see, because some patient, if he enters, you call him immediately, the pulse will be high because he is nervous, no? You are a doctor, what are you going to tell him? Good disease, bad disease. So pulse is that fast. But this patient was sitting for half an hour. And when he comes, you find pulse is 120. Diagnosis over. Finished. It is hyperthyroidism, more thyroid. Now, it's a rare disease. In the whole year, you might see only one case of hyperthyroidism. But in the books, these authors have blown it up. You see, all these authors who write books, they are not doing private practice, they are doing hospital practice. So that is how the whole thing gets complicated. That you read that, you will practice wrongly. Now, these patients with the fast pulse, what are the other causes of fast pulse? Nervousness, yes. Nervousness can cause fast pulse. Asthma drugs are the common. People who take inhalers have just taken 2-3 puffs, pulse becomes fast. Diabetic, rare complication. Autonomic, postural hypertension, who get autonomic nervous system, night diarrhea, they can have fast pulse all the time for no other reason. So, but then these are easy to exclude. And if you got a fast pulse which is irregular, irregular means atrial fibrillation. Atrial fibrillation is a heart disease. It's one of the diseases of the heart, where one of the causes of atrial fibrillation is more thyroid. In olden days, we used to see atrial fibrillation in young women because of mitral heart disease, rheumatic heart disease. We call it rheumatic heart disease. So rheumatic heart disease has disappeared. Why? Because you treat tonsillitis very well, and not only that, they are spotted early and operated early, or without operation also. The mitral walls are dilated with a balloon. We don't see mitral disease in private practice. Well, I will not use that word, because remember that a mitral patient, rheumatic heart disease, even after the operation, he remains a patient. He can still develop atrial fibrillation after 10 years. But what I am saying is this, that once you have a fast pulse, your diagnosis is over, finished. It is thyrotoxicosis, more thyroid. Now in the books, the students remember this disease like this, that if you get exophthalmos, eyes are popping out, staring look, that is thyrotoxicosis, more thyroid. I mean, it's wrong, it's not right. This is a complication of thyrotoxicosis. To develop popping eyes, like one of the film actresses they developed, poor thing, she could not do acting anymore. This is a complication of thyrotoxicosis, and a bad complication. Because once you develop this complication, it doesn't respond to any treatment. You can treat thyroid, you can bring hyperthyroid to normal, but you can't reduce, maybe a little bit. So don't promise the patient, I know, oh, you got thyrotoxicosis, yeah, we'll start the treatment, you'll be alright. No, don't tell him, don't tell her this thing. But what I want to tell you is this, if you want to diagnose thyroid hyperthyroidism by this eye science, you are going to miss hyperthyroidism. You're going to miss. This is due to a disease called as Graves' disease. Graves' disease, you get these antibodies from TSH receptors from the pituitary, and that produces thyrotoxicosis. It's a rare disease. And with complications. You are hardly going to see once a year. Now I'll show you some more, which you're going to see more often as a GP. And possibly you're missing. Even specialists must be missing. Hyperthyroidism. Now suppose you're discussing hyperthyroidism. Then we start doing blood tests. Now today I want to tell you, as a good GP, you are a very good GP if you only know one blood test of thyroid, and that's called as TSH. TSH. TSH is not a thyroid test. Actually, it has nothing to do with thyroid. It comes from the pituitary. This is thyroid. T3 is thyroid. T4 is thyroid. But don't go after the theory. It's very difficult to explain. But all I want to tell you today is that get friendly with TSH level. Very important. 0.4 to 4 is a normal level. Finished. 0.4 to 4. If it is more than 4, then the patient has got hypothyroidism, less thyroid. If it is less than 0.4, patient has got hyperthyroidism. Whatever cause may be, that's not the point. We do see some patients who have no symptoms, nothing. The TSH remains 0.1, 0.2. It's not good. It's bad. Because they have got more thyroid, but somehow they have no symptoms. And thyroid affects those three things I told you. One is heart. More thyroid means atrial fibrillation. Atrial fibrillation is a heart disease which the public doesn't know. GPs don't understand much. It's more serious than ischemic heart disease. I would be very happy if I get angina and myocardial infarction. Why? Because I'll go and get a stenting done. Finish and take aspirin, lifetime. Atrial fibrillation is not like that. Atrial fibrillation we develop clots in the heart, and the first symptom could be paralysis. 1/3 patients of paralysis, 1/3, are all due to atrial fibrillation. It's often missed. Because once you diagnose atrial fibrillation, to prevent these clots and you have to give oral anticoagulants. In olden days we used to give warfarin and all that. Now naturally, if some better drug comes, you have to give a better drug. Now the new oral anticoagulants which have come, they cost nearly 3,000 to 5,000 rupees per month. And this patient will have to take lifetime, to prevent all these complications of paralysis. Not a good disease. Plus heart enlargement, heart failure. Atrial fibrillation is a bad disease. And please remember, you don't cause it and miss it by missing this. TSH remains very low, and clinically there are no signs. Send him to a specialist. See, because the more thyroid affects the heart, more thyroid affects the bones. Osteoporosis. In osteoporosis there are no symptoms. She'll have osteoporosis. He will have and after 5-10 years suddenly fracture. Spine breaks. And the muscles also. Muscles become weak. In my opinion, TSH blood test is one of the best tests which came out. 30-40 years back there was no TSH. Now there is too much TSH. With the result, nearly 10-20% population has got more TSH and they are diagnosed as hypothyroidism. In the blood tests which you do, for example, patient spends 1,000-2,000 rupees. SMA 12 blood tests, 20 blood tests. Most of the blood tests are useless. Useless. The liver, there are 5-6 liver tests. Albumin, globulin, SGPT, SGOT, gamma GT. What? You are doing a normal health checkup. Why should the patient spend money on this test? Sodium, potassium, in a normal person you do. Uric acid, such a useless test, I tell you, uric acid. You are wasting the money. CPK, LDH. Every patient has got high CPK, high LDH. Nobody talks about it. Why? Nobody wants to know. Most of these blood tests which you do in the SMA 12 and SMA 20 are useless. Lipid profile, cholesterol, LDL, HDL, triglycerides. You can make out from the patient clinically. Those people who have got fat here, those who have got drink, smoke, don't walk. So what information did you get by doing this, spending 1,000, 2,000 rupees? But TSH, yeah, yes. TSH gives you thyroid which produces no symptoms, which may have no symptoms at all. So, you don't have to do T3, T4. Then T3, then there are FT3, FT4, means which are more accurate. Free T3, free T4. And then the pathologists will do this test, and if you have say thyroid, they'll do TSH, FT3, FT4, TPO, antibodies against TSH receptors, all not required. For what? You're wasting the patient's money. All you want to know is, and if TSH is low, you have confirmed your diagnosis of hyperthyroidism. Well, you can ask for T3 to see if it is high. T3 will be high. It's a real thyroid hormone. TSH is not a thyroid hormone. Not necessary. And the presence of goiter, enlarged thyroid, may be there, may not be there. May be there, may not be there. When you diagnose Graves' disease, which they write in the books, and as I told you, it's a rare disease of thyrotoxicosis, then you have to do some more tests. For example, nuclear scan. Now for this, you should have a nuclear department in your city, in your town. 90% of India, there is no nuclear department. But if you have a nuclear department, yes, it's very good. You can see more thyroid by injecting iodine in hot, black. And then you have to also demonstrate antibodies against TSH receptors. Not TPO antibodies are common antibodies. Most of the population has got a slight TPO antibody. But the antibodies against TSH receptors only in Graves' disease. So if you ever get this patient, what is the treatment? Either neomercazole or radioactive iodine. Neomercazole works very beautifully. You just give 2 tablets per day or 3 tablets per day. Within a month or so, or 6 weeks, the symptoms are controlled. No loss of weight, more pulse becomes normal. But I personally don't like neomercazole. See, because neomercazole you will give for 1 year or 2 years again. The moment you stop neomercazole, the patient gets again relapse. That's a nuisance. The second thing is, the neomercazole produces goiter, so the thyroid goes on increasing with neomercazole. So the women will not like it. And the worst thing is this complication of agranulocytosis, and which can occur suddenly, which can occur after 1 month, 2 months, 6 months. So it's a tension on the GP. Any day he has got bad throat, fever, this, that, agranulocytosis. Admit in the hospital, intravenous antibiotics. I like to give treatment of radioactive iodine. If you have got no nuclear department there, send the patient out to another city, another town. Why? Because patient has to only go there and spend one day only. They'll do a radioactive scan, and it's like polio vaccine, you give them, given radioactive iodine, given, finish. Treatment is over. Patient goes home, all the symptoms of hyperthyroidism subside. The only problem is of this treatment that after a few years, this iodine destroys the thyroid. Olden days they used to remove thyroid surgically. Bad operation. They remove thyroid, they remove recurrent laryngeal nerve, the voice becomes hoarse, they remove parathyroid is stuck up on thyroid. So you get tetany. Now no more surgery. This iodine goes and destroys the thyroid cells. So when it destroys later on, after some time too much, there is no thyroid in the body. So this patient then develop hypothyroidism. Once you develop hypothyroidism, you will need thyroid lifetime. Not a good disease, not a good suggestion, in the sense that patient can ask you, you are treating me for some disease, and then you are going to produce something for which I have to take lifetime. Lifetime I have to take thyroid. You have to explain to them. It's better than to take the other treatment of Graves' disease. And not only that, rarely Graves' disease patients end up with a hypothyroidism. Hypothyroidism is known. So God did that. You didn't do it. So I am very convinced that all patients who are 40, 50, you can't give to young people. You can't give to pregnant women. You must send them somewhere and get a treatment of radioactive iodine. One drop there, they come back home, no other treatment required. Now, what is written in the books, as I told you, is done by full-time professors. They have not done private practice. You see. In private practice, I am telling you, as a good GP, you should know this also, that the commonest cause of hyperthyroidism is subacute thyroiditis. Subacute thyroiditis. It's a virus. It's a virus, but also antibodies. Maybe antibodies are involved in it. But possibly starts with virus of the thyroid. So patient gets this virus illness. So patient gets fever. And patient gets pain in the thyroid gland, which is mistaken for throat. So patient will say, open the mouth, throat infection. Treat it as throat infection. ESR is high. It's a very, you are going to see, in my opinion, although you will not see a case of Graves' disease even once in a year, this, if you pick up and if you become conscious, you're going to pick up 2 to 3 patients per year of this disease, which is causing hyperthyroidism. Hyperthyroidism. No eye signs, no exophthalmos, nothing. With the result, easy to miss, very easy to miss. But what will draw your attention is that these patients, when they get fever, little high ESR, pain in the throat, they lose weight very fast. So within 4-6 weeks, if they have lost 3-4 kilo, they get concerned. Why do they lose? And while the doctor thinks ESR high, we lost weight, maybe tuberculosis, maybe cancer, maybe. With the result, these patients, I always bring on the stage every year a patient and show to the doctors that patient was admitted in the hospital for PUO with a high ESR and discharged with the diagnosis of PUO, no diagnosis is made, but with hyperthyroidism. These poor consultants, hospital doctors, have not understood that subacute thyroiditis causes both this. So if you see a patient with symptoms of hyperthyroidism with fever and pain, throat pain, ESR is high, that patient has got subacute thyroiditis. Really speaking, in all our big cities where nuclear medicine departments are available, if you do a radioactive iodine uptake in this patient, you will not find hot. You will not find hot. You will find nothing here, iodine which you inject, which is an important contrast, that the thyroid is very high, and yet if you inject the iodine, there is nothing here. Diagnostic of subacute thyroiditis. You don't have to do it. You don't have to send the patient. You make a diagnosis, and then treatment is nothing. Nothing means what? They've got tachycardia, they've got palpitation, they've lost weight. The symptoms of hyperthyroidism. And you go on giving them propranolol to control the pulse rate. Finished. Propranolol to control the pulse rate, a little better diet so that they don't lose more weight, and the whole illness passes off. It passes off. 2 months, 3 months. But it's very interesting. This illness, if you have diagnosed, follow up these patients. Because we don't know what is going to happen to them later on. You see, that same hyperthyroidism, after a few months, 6 months or so, they might develop hypothyroidism because of subacute thyroiditis. If they develop, you give thyroid, but it's not lifetime thyroid. It will be just for a few months, and patient will be. So if you see hyperthyroidism, it will be subacute thyroiditis. Please remember, as a good GP, you only tell the patient, nothing to worry, take beta blockers, good diet, it will go away. It will go away. ESR will come down. When you come to hypothyroidism, it is opposite. The hyperthyroidism diagnosis I told you is made in 1 second. 1 second. Hypothyroidism is all rubbish. There are no symptoms of hypothyroidism. They are all manufactured by blood tests, by patients talking, by patient hearing. With the result, there are so many symptoms which are attributed to hypothyroidism. For example, obesity. Today obesity is international, all over the world, because more calories, more diet, less consumption. Gaining the weight. That's, you have to check your diet. That's the commonest cause. Puffiness. Yes, that I'll show you. If you have a little weight gain, any puffiness, you suspect hypothyroidism. Puffiness of the face. In women, menorrhagia, joint pains with a normal ESR. So joint pains with a normal ESR can occur in hypothyroidism. But as I said, carpal tunnel syndrome, somebody described in the book. I have discussed this before with you. When I told you how symptoms here are so common, you get normal people tingling numbness and you put a ruler at night and early in the morning remove it. It's common in normal population. Yeah, it may be a little more common in hypothyroidism, which doesn't become a symptom of hypothyroidism. With the result ki hypothyroidism, fatigue, lethargy, weakness, everybody complains of that. Because nobody does exercise, they go on putting weight. And in women, if at all you want to make a differential diagnosis of these symptoms, please remember anemia is more responsible for these symptoms, anemia. If your hemoglobin goes down to even 9 grams, 10 grams, you will develop symptoms of fatigue, lethargy, weakness. You will respond to iron within 6 weeks. And you are blaming thyroid for that. So all these symptoms which have been mentioned in the books and which the public thinks, cramps for example. I have discussed these cramps before. We don't know the cause of cramps. Homeopathic. So you quinine, 100 milligram quinine you give and the cramps disappear. But cramps maybe are slightly more common in hypothyroid patients. Snoring. Snoring is universal in all fat people. I have discussed it when I discussed these athyars, that you put that ball there so that patient sleeps on the side. If he sleeps on the side, loses 10 kilo weight, starts walking, snoring is okay. The sleep apnea syndrome is rare. The hair loss, dry skin, attributed to hypothyroidism. No, hair loss is universal. Everybody is losing hair. I tell them it is due to radioactivity, more radioactivity in the air. Dry skin. Nobody ever puts oil. You see, I come from Punjab. In Punjab, when we took bath, we first used to put oil in the skin, all over. Oil massage, then take a bath. Here nobody puts oil at all, and then they complain of dry skin. I'm not impressed. All these symptoms are normal symptoms. Hearing less. Naturally, these menopausal women of 60, 70, always slightly hearing less is common. Feeling cold, even otherwise, feeling cold, feeling hot is a normal variation in the population. Constipation. It's a universal symptom. How can you say constipation is due to hypothyroidism? To avoid constipation, you must take a lot of fruits, a lot of fresh vegetables and fruits. And who has got the money to buy all this? Nobody has got. So, according to me, there are no symptoms of hypothyroidism. No. The days are gone. Yes. We used to see plenty of severe hypothyroidism, which is called as myxedema. And myxedema, and if you are in a cold country like Canada, for example, you can die of myxedema. You can go into coma and die also. In our country, there is nothing like that. No myxedema. No deaths due to low thyroid. So, I was telling you, if at all the symptom and sign of hypothyroidism is face, puffiness of the face. Now my man has put this to cover the eyes. I can't show the eyes. I wanted to show the eyes because you're not supposed to reveal the identity of the patient, because she has got puffiness here. She has got puffiness here. That puffiness is more important a sign than fat. Now, for example, this lady, she's puffy. She's not fat. She's not fat. She's a fat. Eyes are puffy. Face is puffy. The whole thing is puffy. And after the treatment, beautiful. This was myxedema we used to see in the past. We don't see. Now, this doctor, for example, I diagnosed at home. His brother is my friend. I went to have a cup of tea. And I saw this fellow. This picture is taken in the studio. So they have done this, see, color here, this color in the, here. No, he had nothing there, no hair, half the hair. His hair was very bad. Face was swollen. And he was so slow. When I asked him, what is he doing? He was supposed to be a medical student. He was an excellent, always first, second. And now it seemed later on he started failing. And now he's sitting at home. 1 second diagnosis. I said, this is hypothyroidism. And within 6 weeks of thyroid, look at the face. The same man, 6 weeks, is a different man. So this puffiness See the puff, the whole face gets puffed up. That is diagnostic of hypothyroidism. I have picked up so many of these patients who have got this puffiness below the eyes. No, it's normal. No, it has nothing to do with thyroid. Here is another woman also, somebody will say, oh, she is low thyroid. No, these are normal things. There are no hypothyroidism. So, yes, this is called puffiness. This lady came to me from Ratnagiri and saying, doctor, ये क्या है? ये सब सूजा हुआ है. Look at the puffiness. This side, the light is more there, no? So you can't see this side. This side is same like puffy. And the whole face also is puffy. Little like a wax. Puffy. And then she told me, you don't remember me? I had come to you for this and you treated me 12 years back. I remembered. 12 years back she had come for thyrotoxicosis, exophthalmos, and I treated her with radioactive iodine. With radioactive iodine the whole symptoms disappeared. This does not disappear. This will not respond. So she is living with the big eyes. But after 12 years now, the thyroid has now become zero. Radioactive iodine has destroyed the whole thyroid. Now she has developed hypothyroidism. Now she'll have to take thyroid lifetime. Now, this is the most important slide for today, I am telling you. We are going to finish in 5 minutes, but I want to tell you, TSH is being done in every patient, and sometimes the reading is a little different in different laboratories. So the GPs will get confused. Normally is up to 4. Suppose it is 6, 8, 10. Patient has no symptoms. I told you, hypothyroidism produces. They will go on saying, my weight. I took thyroid and within 4 or 5 days the weight went down by 3-4 kilo. That is because of diuresis. All fat people, when you want to reduce the weight, you give them a diuretic with a diet. So they pass more urine and they lose 2-3 kilo weight. There are no symptoms of hypothyroidism. No, it's a routine incidental finding. So suppose you find, and there are many such patients who will come, that it is not up to 4, it's more 6, 8, 10, 12, 14. And they will start saying, doctor, I have got less thyroid, the doctor has seen it, and therefore I get these pains, oh therefore I get the backache, oh therefore I get this cramp, and therefore they will attribute everything, therefore my hair are not very good, therefore my skin is dry. No, wrong. These symptoms are not due to that. In fact, I even don't bother up to 20. Even up to 15, 20, I will not start the treatment. Why? Because you are forgetting. You are like a judge who is giving a lifetime sentence. You want to give a lifetime sentence to patient that you got less thyroid and take thyroid lifetime? 30, 40 years? Tablet early morning on empty stomach or late night before going to sleep? Most of them forget it. So often they forget it. It's a nuisance. You go out of Bombay, you don't carry your tablets. You go somewhere, it's not available. You must not change your brand. The same brand is not available. So there is a lot of nuisance of taking it lifetime. So you want to decide, should you start thyroid or not? So I'll tell you, there are 3 things which can help you in that. Number 1, you can ask for T4. Free T4 level, not T3. T3 will be in thyroid, more thyrotoxicosis. T4, F, is more accurate. If it is normal, so thyroid is normal, then don't start the treatment. Don't start the treatment. Tell the patient, what is the hurry? You're going to take lifetime. What is the hurry? I'll wait for 6 months. If it goes up still more, and if this falls, becomes less, I'll start thyroid. Then you take lifetime. What's the problem? Unfortunately, doctors don't do. All the GPs, moment they see this thing, start thyroid. Second thing is level of TPO antibodies. Those people who have got very high antibodies, they are likely to have real hypothyroidism. You can start thyroid. And the most important, family history. Most important. And it runs in the families, low thyroid. So if the family history is positive, you can start. Otherwise not. Otherwise wait. No hurry. Let it rise to 20, 30, 40, 50, 60. ECG doesn't help. Low voltage sometimes. And when you have dealing with an elderly person, are you sure he has no ischemic heart disease? Because if there is a ischemic heart disease, that patient, very dangerous. Very. Old people, in fact, first of all old people never give more than 50 microgram dose. 100, 150, and not for young people. Old people, always after 60, 70, 50. Let TSH remain a little high, nothing wrong. Why? Because the heart, if you got ischemic heart and you give thyroid, the patient can die suddenly. He can have a heart attack. So please remember, before you even want to start thyroid, but look at the age of the patient and family history, etc. Has he got ischemic heart disease? If so, first attend to that. Angiography, put a stent. Then start the thyroid. Not before that, because otherwise that can cause an infarction. In olden days, how many people used to die suddenly by taking thyroid? All because when this was not known. Sudden death. So in young people, etc., you can always start with 50, increase to 100, 150, and once a year at least the blood level should be there, seen. Why? Because by chance, suppose that thyroid becomes more, TSH becomes less, that patient is more liable to get atrial fibrillation, muscle weakness, osteoporosis. Finally, there are, when you do TSH levels, remember that patients of tuberculosis who are taking these drugs, the TSH can become high. So they can develop hypothyroidism. So if a patient is suddenly putting on weight and a little puffy, amiodarone, heart pain, notorious chemo drugs, notorious for causing high TSH. But of course, most common is what we produce by our radioactive iodine treatment of hyperthyroidism. Hyperthyroidism, Graves' disease, when after a few years these patients develop hypothyroidism. So, my advice to you will be, don't use the word thyroid. What thyroid? Examine the thyroid. Ask the symptoms. And then go by TSH, only TSH. When the TSH is high, hypothyroidism, no hurry, no tension, no worry. Don't frighten the patient, because a lifetime he'll have to take. Take your time. Wait. Repeat it after a few months. TPO antibodies, family history, free FT4. And yes, I do agree that hypothyroidism is being maybe diagnosed better. In the past we did not diagnose with TSH, but I find now rampant, like asthma. Nearly 20-30% patients have got hypothyroidism. Thank you.